Good evening, everybody, and welcome to this evening's webinar. We're delighted to be joined by Dr. Kate Petheram this evening to discuss the very important topic of menopause and MS. I just want to say a big thank you to the Southeast team for organising this event. Our many thanks to them. As always, with our webinars, you are invited to submit your questions throughout the session. We will hold the questions to the end. So there are two functions on Zoom which you can submit questions through, and that is through the Q&A function and through the chat function. So we will be keeping an eye on those, and we'll be holding the questions to the end. So I will quickly get started and introduce Dr. Kate Petheram. She is a consultant neurologist with a special interest in multiple sclerosis. She is MS lead at South Tyneside and Sunderland NHS Foundation Trust and works with a small but dedicated MS team within the District General Hospital there. The team provide a full range of DMTs with the trust and participate in MDT meetings and neighbouring Newcastle. She studied medicine in Bristol and stayed in the Southwest to do her medical training in Bristol and Exeter before moving to London for junior doctor roles in the neurology departments at St George's and then the Royal Free. She made the move to the North East to undertake neurology specialist training before taking up her consultant post in Sunderland in 2014. She's a local principal investigator in a number of MS observational studies, and she's a medical assistant for the MS Society and is on the faculty of the MS Academy. She is a member of the Quality Committee for the Association of British Neurology and is also trained at the training programme Director for Neurology in the North East. So with that, we'll hand over to you, Dr. Petheram. And again, thank you so much for joining us this evening.
So thank you. Hopefully you can see my slides now, Aoife, is that right? Or oh, you're on mute.
Apologies, we can't just yet. We can see your overall screen, but not your slides.
How about now? Is that better?
Yes, that is much better. Yeah. Thank you.
So thank you so much for inviting me to speak to you all this evening. It's a real pleasure. And thank you for the very kind introduction as well. So you may be wondering really why I've been asked to speak to you, why a neurologist is talking to you about menopause and MS and why we're talking about it at all. First disclaimer is that I'm not a GP or a gynecologist, so I've come to this interest in MS and menopause over the last few years with the recognition that it's a really important subject for us as healthcare professionals, but also patients to be aware of, with the recognition that at any one time, 30% of our current MS population are either perimenopausal or postmenopausal women. So there is much more awareness and understanding about menopause in general, not least because of this lady and a lot of her TV appearances, social media and books, and that's caused a lot more awareness to more generally. But also, and apologies because I appreciate that I'm speaking to an Irish audience, and this paper has come out from England, but I think it was quite timely. It came out last year and just highlights that menopause is an area of medicine which has been understudied and is underaware of. And this paper highlights that other healthcare professionals and picks out cardiologists and neurologists need to have a basic understanding and awareness of the symptoms and future health risks associated, so we can best signpost and signpost women appropriately. So that was really timely, and it's an area that I've become really interested in. And this is important as well because whilst I'm not a gynecologist or a GP, so I'm not going to be the one that's prescribing HRT, it's really important that we empower patients. And this is an example of a letter one of my patients notes, who was in the past been told that she couldn't have HRT because of her multiple sclerosis, and that's not true. And so that's a kind of myth we need to break down and change. These are quotes that came from, I'm sorry, the colours changed, but so they project brilliantly on the screen, but are quotes from patients. So Rachel Horn is a lady with MS who's also a journalist. It's quite active on X, or what used to be Twitter, and got this information from patients. And a lot of, I think, people feel that they are caught between their maybe MS neurologists or general neurologists and their GPs, and nobody really knows what the best advice is. And I think lots of people, feel that they really have to advocate for themselves really hard to get the treatment they feel they need. And I think we need to be aware of where MS fits into the HRT and menopause pathway. So I thought it might be helpful just to go through a few of the key facts about menopause. So menopause is a clinical diagnosis, and it's only really able to be made in retrospect. So it's defined as the year after the last menstrual period. But I think importantly, it's important to recognize that with the perimenopause, so that time around the menopause, it can last up to 10 years. And so we need to be thinking about this in people potentially earlier than we think we might need to. And so the average age in Caucasian women is 51, but obviously with a range, and not, it's less common, but not super rare to have premature ovarian insufficiency. So 1 in 100 of under 40, 1 in 1,000 under 30. And so I really think we, as healthcare professionals and patients, need to be aware of hormonal factors, really from the kind of early mid 40s right through to the kind of late 50s and beyond. I think it's important to recognize that not all women will have symptoms of menopause, but 3/4 of people will. And of those, 25% will describe their symptoms as severe and kind of life-changing and potentially quite disabling. And those symptoms are not something that are just going to necessarily last a few weeks or months, but may go on for many years. But as with everything, is different in each individual. So this is just a kind of picture to demonstrate that we know estrogen levels change throughout a woman's life. So increase into their maximum in the kind of high reproductive ages in the mid 30s, and then start declining after that. So it's not a kind of on-off switch. Obviously, there will people that have a sudden menopause after a surgical procedure that might render them menopausal, but for most women, it will be a steady decline. And I think that brings me on to the point about diagnosing the menopause in general. And I think it's important to recognize that it's a clinical diagnosis based on symptoms. And I think this is an area that's a little bit controversial about measuring blood hormones. And I certainly hear anecdotally from patients and kind of friends that particularly at that kind of slightly grey area of early mid 40s, the temptation is to measure hormone levels within the blood and trying to diagnose menopause that way. The NICE guidelines in England say you definitely, they should not be based on hormone levels, certainly over the age of 45. But I think most people, most menopausal experts will not menopausal, but experts in the menopause will recognize that, even in younger women, measuring blood hormones is not the only route into a diagnosis of perimenopausal symptoms or menopause, not least because hormone levels will change dramatically throughout the kind of cycle and throughout the day even. I think the main reason for doing bloods in a diagnosis of menopause is to exclude other causes of the symptoms. So, for example, checking that somebody's not anemic or hasn't got thyroid dysfunction. And so that really should be the main purpose of checking hormone levels, particularly in the kind of over 40s. Below 40s, it probably is reasonable to base your diagnosis on hormones. So I often recommend to patients and friends that they use an app, for example, to monitor symptoms, and then you can go to your healthcare professional with a kind of list of symptoms that can, may be associated with cycles. A change in periods is often the first sign of the menopause approaching, but isn't in everybody, and you can still be perimenopausal and have regular periods. So the common questions that I hope to try and answer today, in part at least, is these questions. And these are the common questions that we get asked: is, does the menopause affect MS itself? What are the benefits of HRT, both from a general health point of view, but also from an MS point of view? And similarly, what are the risks of HRT? Because I think that's a big concern for people and is important to be aware and understand the risks properly. And then are there any alternatives to HRT? And I'm going to spend a little bit of time as well disentangling the different symptoms and potential management of the overlapping symptoms. So there's a diagnostic challenge, isn't there? So we recognise that we have MS, common MS symptoms, which are listed here. I'm not going to go through them all individually, but hopefully you recognise these, as quite common symptoms. Not everybody will have them, but a number of MS patients do. So fatigue, sensory disturbance, cognitive pain, sexual dysfunction, mood issues. And then on the other side, I've listed, common, if you Google symptoms and menopause, these are the common menopause symptoms. And what I think is quite telling is if you then tally them together, then you realize that there's quite a lot of overlapping symptoms. So I think this is the main challenge in patients or women with MS who are going to go through the menopause, recognizing that we make the diagnosis of MS often between the ages of 20 and 40. So going through the menopause is something that's almost certainly going to happen to women with MS. And when you get symptoms like this, it's really hard to know whether it's due to the menopause or whether it's due to your MS or a combination of the two. And these, I think, I've identified through my clinical practice and talking to patients, the kind of top 3 overlapping symptoms which are important to recognise and address. So difficulties with sleep and fatigue, difficulties with mood, cognition and mental health. And I realise that's probably quite a lot of symptoms lumped together, but it highlights the issues. And then perhaps most complicatedly, but really important to recognise, is urinary symptoms and sexual health and sexual dysfunction issues, which can occur in both. So I think there are other health risks from the menopause that women are at risk of and are important to highlight because they overlap with, our desire to manage MS holistically and manage comorbidities, so other medical problems that people can have. So we know people can, with the menopause, people can more likely to get bone thinning. And that's an issue if you've got multiple sclerosis, and you might be more prone to falling because you're at risk of having broken bones and fractures. Menopause predisposes to a change in the fat distribution, so more central, fat distribution around the belly, raised cholesterol levels, high risk of cardiovascular disease, diabetes, and arthritis. So I think it is, it's definitely something that we need to be aware of and be talking about and dealing with. So I thought I'd spend a few moments now talking about HRT, so hormone replacement therapy, and talking a little about what it is. I'm sure most of you are aware, but it aims to replace the estrogen. So that's the hormone that's is felt to be causing, or the lack of estrogen, which causes the symptoms. And there are many different ways to take estrogen. So it can be taken, 3 main ways to take it, although there are about 50 different ways of having HRT. So it can be taken orally as a tablet. When we say transdermally, that means through the skin, and that can be either as a patch or a gel, or it can be, I think this is less commonly used, but used as an implant, which is injected under the skin, which provides a more slow release of estrogen. And I think it's important to also highlight the use and importance of vaginal estrogens. So taken either as a vaginal tablet, cream or ring inserted locally. And I'll talk a little bit more about risks and safety, but that's an alternative, or addition can be used as an alternative to taking kind of tablets or patches HRT, so what we call systemic HRT, but is very safe and can be used in some people that maybe not be able or not wish to take other forms of HRT. So the next slide is a slightly complicated treatment guide, and I put it up there as an illustration. I'm not expecting everybody to kind of study it in great detail. And again, I said I'm not a kind of prescriber of HRT, and there are 50 different types of HRT. But essentially the type of HRT depends on whether you've got a womb. So if you haven't had a hysterectomy and you haven't got a Mirena style coil-in, then you need to have a combined estrogen and progesterone. But if you don't have a womb, or if you've got a Mirena in, you can take estrogen only. And there are various ways of doing that and various combinations of doing it. So what are the benefits of HRT? The primary aim of HRT is for control of symptoms and quality of life. So that's the main reason to really be prescribed HRT. But increasingly, we are recognizing that it does provide protection against cardiovascular disease potentially, and that works better if you start it soon after, soon around the menopause, and certainly under the age of 60. So it's felt to be protective in that situation. And it does increase the strength of your bones and therefore reduces your risk of fractures. And there is some feeling that it might relieve short-term cognitive symptoms, so those thought processes, brain fog, word finding difficulties. The jury's still really out as to whether it's going to have an effect on long-term, risk of dementia, and there are conflicting studies, and so that we need a little bit more information before being sure about those things. So this is just apologies for the kind of technical side of this, but this was just to illustrate that this is a fairly recent, long study of the use of hormone replacement therapy in the UK, matching those people using HRT with those not, and found that actually people that used HRT had a 9% lower risk of mortality, so risk of dying, if they were on combined HRT, and there was no difference if they were on estrogen only. So quite reassuring in terms of risk of death, certainly, if that's something which we'd all be concerned about. So you may be wondering kind of what's the big deal then? What's the why isn't everyone on HRT? I've made it sound really safe. There are lots of benefits, but there has been a lot of controversy surrounding HRT, and I thought it worth maybe explaining the background to this. So here you see a graph, a proportion of women who are prescribed HRT from the mid 80s through to the kind of mid 2000 teens. And what you see is a massive drop off in a prescription of HRT following in the kind of mid 2000s, early 2000s. And this followed the publications of a study called the Women's Health Initiative. And that was a large study of postmenopausal women who were treated with HRT, and it looked at the risk of cardiovascular disease and breast cancer. And it reported an increased risk of breast cancer on women taking HRT. And there's always a but, isn't there? I think it's important to recognize that the women that were in this study were North Americans in their mid-60s, and they were often overweight. And actually, if you looked at the long-term randomized control data, that showed a reduction in breast cancer diagnosis and death in women using estrogen-only HRT. Combined HRT oral preparations has an increased risk of breast cancer, but no increased risk of dying. And importantly, this study did not include women who were perimenopausal, so around the time of the menopause, or who had symptoms of the menopause. So it excluded a large group of women that potentially benefit from HRT. It was, the interim reports were, leaked by the mainstream media, and that's what caused that kind of media storm that you saw about HRT being dangerous. So I think it's, to put this in perspective, I include the next slide, which is breast cancer risk. And this is an infographic which you can find on the Women's Health Concern website, which is the patient's arm of the British Menopause Society. And I think that has some really good resources and fact sheets if you're interested in finding more about HRT and risks in general. And so this kind of picture shows the difference in breast cancer so the number of women being diagnosed with breast cancer per 1,000 women aged between 50 and 59. And so if you look at the numbers there are an additional 4 cases in women on combined HRT, but for fewer cases on estrogen only HRT. And if you look at the other risks, particularly being overweight or obese is a much, much, much higher risk of breast cancer. Smoking increases your risk by almost as much, and drinking 2 or more units of alcohol per day increases your risk as well. Encouraging there are things you can do to protect and reduce your risk by taking exercise. So 2.5 hours of moderate exercise per week can protect your risk or reduce your risk of breast cancer. So that's the breast cancer thing partially covered, hopefully. There are other concerns which can be brought up about risks of HRT, and there is a very tiny increased risk of clots in the veins with oral HRT, but it's less than 1 in 100 5-year risk in the lung, which is twice the risk of patients not taking HRT. But put it in perspective, it's less than women using the oral contraceptive pill and less than pregnancy. So there is a slightly increased risk of stroke in the over 60s, but that on taking HRT, but that risk is less with patches or gel. And the heart disease thing, I think, is not so much a risk. I put it in there because people worry about it, but the current evidence suggests that healthy women who are taking estrogen only or combined HRT within the 10 years of the menopause starting or under 60 are in fact protected from heart disease and have less risk of heart disease or dying from heart disease. So I don't necessarily think everybody should be put on HRT, but I think this has to be a discussion between the person considering it, the person going through the symptoms, and their healthcare provider. And that has to be a joint decision making in an ideal world. But I appreciate that's not always easy. So I thought I'd talk a little bit about the alternatives or the adjuncts. So that's something you can use instead of or as well as HRT. And sorry to bang on about it, but lifestyle modifications are really important. So looking at, this is general kind of MS lifestyle advice. So looking at diet and exercise, stopping smoking, and reducing alcohol intake. And I'll talk a little bit more about the specific symptoms that they might particularly help with. Herbal alternatives, I'm going to talk a little bit about on the next slide. St. John's wort, black cohosh, isoflavone. There are kind of very small studies suggesting some benefits in symptom management, but the evidence isn't desperately compelling. Magnesium is fairly safe. I recommend it to lots of patients, particularly for sleep. Clonidine and gabapentin can be useful for hot flushes if other things have failed. And similarly, gabapentin and antidepressants are sometimes used to manage hot flushes and some of the mood disturbance that can occur with the menopause. So a little bit more about complementary treatments, and I was reminded this. I gave a similar talk to some MS nurses a couple of weeks ago, and it is really worth remembering that St. John's wort can interact with other medications, including fingolimod. So that's a disease-modifying therapy for MS. And so it's really important that you don't take something like St. John's wort without talking to your MS nurse or MS neurologist. But I would probably recommend avoiding it because measuring that interaction is quite challenging. Agnus castus, I've certainly got some in my cupboard. I can't guarantee I take it regularly, but it's said to help with the kind of hot flushes. So that's what we mean when we say vasomotor symptoms and some mood disturbance. Again, there's small studies looking at the other ones I've just talked about. I do put all this statistic in as well, that the global wellness industry is worth a lot of money. So $4.5 trillion US. I was horrified when I read that statistic, and I went up and looked how much the global pharmaceutical industry is worth, and that's worth a lot, but it's worth 4.5 billion. So a magnitude more, so magnitude less than the global wellness industry. So I think we just need to be aware when we see on social media the latest, Davina or the latest celebrity, trying to, get us to buy the latest supplement or tool, that sometimes they may work for individuals, but there isn't a lot of evidence behind them often. So what I say to people is, by all means, give it a go. And if it works for you, fantastic. But don't break the bank over it. And, I think it's about an individual choice. So the next big section is, does the menopause MS? And this is in a way much harder, because although there's much more research going on at the moment about this subject, up until really 2015, there were hardly any studies at all. So, and this illustration just tries to illustrate that the interaction between hormones, so estrogen and MS activity, is quite complex. And I'll talk a little bit about more of this, but we know that there's, more, the prevalence of MS is greater in women, but tends to, you get your peak in instance when estrogen levels are perhaps on the rise. Yet we know that pregnancy is protective against relapse, and that's when your estrogen levels are at the highest. And then perhaps progression and worsening symptoms come at a time when estrogen levels are lowering. So it's not as straightforward as high estrogen is good, low estrogen is bad. It's more complex than that. So this is a study, so it's a summary of the different studies looking at the effect of menopause on the clinical course of MS. So, does the menopause, lead to more relapses, or does it lead to worsening progression? And I think the bottom line is that there isn't good evidence either way. There seems to be perhaps a trend for progression getting worse after the menopause, but we have to acknowledge that we know that MS has a tendency to progress, with age, and so it's difficult to take away that effect of aging and getting older that has on person's MS, and it's difficult to kind of take that out of equation when we're looking at menopause, which is going to happen at the same time. So that's partly what makes the studies quite difficult to do. And finding controls is really challenging as well, because we know MS in men behaves differently to MS in women, and having a control, it's quite difficult it's virtually impossible to find, age matched controls that won't be going through the menopause. So that also makes finding the evidence quite challenging. The other question is, does HRT affect MS disease course? So are you at risk of having more relapses or worse progression if you take HRT? And there are very few studies looking at this. And this is a study that's often quoted to answer this question. And I don't think it does answer it, but it's all we've got at the moment. And it's a Danish registry study, so looking at women from Denmark. The first thing to note is that a very small proportion of these patients studied had actually received HRT, so 10%. The study didn't find an association between HRT and disability getting worse, although there was a possible trend of getting worse if people were on HRT for more than 5 years, and a possible increased risk of relapse in current users. But I think it's really important to recognise that this study was done prior to the use of high efficacy, so highly effective disease modifying therapies. So I think this is interesting in that they've looked at it, but I don't think this is a study that we can use to take really, strong conclusions from. And I certainly would not use this as evidence that we shouldn't be using HRT in women with MS, and quite the opposite, perhaps. So the other really important thing, and we talked about the overlap of symptoms, is that, does HRT have an impact on MS symptoms? And again, very difficult to distinguish whether what we're looking at is symptoms caused by MS or menopause. And this is, I think, got a very old study and a very small study, but it did show that 3/4 of the women who were treated with HRT reported an improvement in what were perceived to be their MS symptoms. So there is a suggestion that HRT may improve some symptoms of MS. Again, another study looking at HRT and quality of life. And this study showed that the women that used HRT reported better quality of life on some of the questionnaires that they used. It's difficult, again, to know whether that is cause and effect, or whether there's just, perhaps those that were more engaged in their healthcare were perhaps more likely to be on HRT, and that might reflect it. So again, it's always very difficult to take these studies and say this is cause and effect. So my interpretation and my summary of the data to date is that the results are mixed, and that it's difficult to separate the impact of menopause from the impact of natural aging, as I described, because the symptoms overlap and the symptoms may last for many, many years. So we need longer studies. A lot of the studies only last for a couple of years and don't really give us necessarily the information that we need. And I alluded to the fact that it's difficult to find controls. But I think that HRT, what we can say is that HRT may help symptoms. We don't really know if it affects disease activity significantly. So on the back of that, I'm often asked the question, or the question has always occurred to me, is estrogen an anti-inflammatory? And I touched on this at the beginning of this section with that picture. And I think the kind of summary of this is that in general, high levels of estrogen appear to be protective and anti-inflammatory. So going back to the point that, that people have, the studies show that there's less risk of relapse in pregnancy when estrogen levels are high, but then an increased risk of relapse postpartum, so after the baby's been born, because of the drop in estrogen levels. And that's been reflected as well in mouse models about the anti-inflammatory effect of high levels of estrogen. There are a couple of studies which did trial estrogen supplementation, mainly in the form of oral contraceptive pills, in combination with injectable DMTs, so either interferon or Copaxone, with moderate benefit. And I think the reason that probably hasn't been taken forward is, the risk of very high levels of estrogen in perhaps non-menopausal women might outweigh the potential benefit. So I thought I'd mention a little bit about testosterone. I think this is a slightly controversial but topical issue, so important just to touch on. And I was certainly asked about it whenever you don't mention something, it's always what people ask about. So testosterone is produced by the ovaries and adrenal glands in women. Levels decline between the ages of 20 and 40 and then kind of stayed the same. So then it's not reducing in the same way that estrogen is. There are some studies suggest that women with MS have less testosterone than women without MS. And there is a small study of 10 men with relapsing MS who were treated with testosterone gel, and that improved their thinking and reduced the brain shrinkage. So there potentially is a role in inflammation and neuroprotection. But the guidelines are quite clear, and it's currently only indicated for reduced libido and reduced sexual desire in women. And it's an off-license indication for testosterone. So I think it can be quite difficult to get hold of. And certainly the British Menopausal Society, recommend its use only for patients that have, or women that have reduced libido when other measures haven't worked. And we don't have, I don't think, sufficient evidence to say that it's definitely neuroprotective, although there is interest. So I thought I'd spend a few minutes talking about some specific symptom management with these overlapping symptoms of MS and menopause. So hot flushes, I mean, that is the stereotypical symptom of MS. Oh, sorry, not of MS, of menopause. And it affects the majority of menopausal women, but not everybody, and it's not a prerequisite to have hot flushes. The issue with women with MS are going through the menopause is that we know that lots of patients with MS are very sensitive to heat fluctuations, particularly getting hot. So it can trigger this phenomenon called ERTOS phenomenon, where your symptoms get worse when you're hot. And that could be really quite disabling for women. And, and there's increasing recognition about the importance of managing that and its effect on, its kind of onward effect on mood and sleep, and that can trigger kind of fatigue, and it's a bit of a vicious cycle. So as well as HRT managing that symptom, there are lifestyle things. So, the use of aircon or cold drinks, fans, stopping smoking, weight loss, back to that. And I sometimes recommend to my patients in the very hot weather that they use a kind of cooling pad or bed. You can often get them randomly in pet shops to keep pets warm, cool in the hot weather. But some people find those really useful. In situations where either HRT isn't appropriate and my lifestyle factors haven't been effective, then some patients can be managed with gabapentin, pregabalin, and some of the antidepressants, but we are trying to get away from overprescribing these things if at all possible. Another big overlapping area is cognition, so thinking, so problems with memory, attention, and word finding. And it's common in MS, it's common in menopause, and it's likely that kind of the menopause will magnify those MS-related cognitive symptoms. And as well, I go back to the importance of lifestyle modification in terms of managing that, but also, again, the other issues of addressing sleep and mood. When I have people that are worried about memory disturbance, those are often the first things that I ask people, particularly mood, because we're aware that memory is kind of relies on your concentration and attention, and if anything is affecting that, such as poor sleep or low mood, then that will have a knock-on effect on your ability to remember things. And again, leading on to low mood and anxiety and depression, we're well aware that both MS and menopause can lead to problems with anxiety and depression. And I think, again, it's a combination of lifestyle factors, potentially medication interventions, and we shouldn't be afraid of those if we need to use them. And antidepressants may be appropriate for some people, but and I know I don't know if people are aware, but in England, the draft updated NICE guidelines for menopause were, I think, released this week, and I think it's caused a bit of a media, or certainly social media storm, that one of the recommendations for treating menopausal symptoms is to refer people for CBT, and I think people feel that that's perhaps undermining the importance of other treatments. And so I wouldn't necessarily say that has to be instead of a consideration of HRT, but it might be necessarily in conjunction with it. And I put ACT here, so that's acceptance and commitment therapy, which I think can be a brilliant alternative to CBT, and sometimes it's much easier to assimilate into your kind of daily life. And there's quite a lot of self-help literature out there on ACT therapy. Another biggie is urinary symptoms and sexual dysfunction. Again, we know that's really common in MS, but we also recognise that particularly vaginal dryness and potentially loss of libido, which may be connected, can be really common around the menopause. And this is one of the situations where it's really difficult to determine what is MS and what is menopause. And I think that this is also one of the areas where there's a lot of lack of awareness, particularly you'll find, unfortunately, amongst neurologists, and possibly more so in neurologists of the opposite sectors to myself, who will not necessarily be aware that menopause could be a potential cause of urinary symptoms. And I think that's, potential area of that, as a healthcare professional, I need to educate my peers. But it is often difficult to tell the difference. And I think it's reasonable to say that where women have no other, no prior history of sexual or urinary symptoms, and the onset of these symptoms coincides with other MS symptoms, then you should consider new MS activity before attributing symptoms to the menopause. However, where the sexual or urinary symptoms develop in the context of other menopausal symptoms and there are no other new neurological symptoms, then it may be more appropriate to treat as a menopause. And then treatment can be a combination of all these things, of education, counselling, but sometimes medication, pelvic floor exercises. And again, this is where I bring up the use of lubricants and topical estrogens. And topical estrogens, so vaginal estrogens, are safe regardless of a family history or even personal history of breast cancer. So a lot of this is, I think there isn't a lot, this is potentially a bit controversial. Well, it's not controversial, but perhaps isn't well known, but you can use topical estrogens. It's a risk-benefit discussion, obviously, to be had with your kind of primary care doctor, potentially oncologist if it's relevant, but you know, is appropriate to use topical estrogens in some people with breast cancer. Fatigue, the most common symptom of MS. So 90% of patients with MS will suffer fatigue, and we know this is a really difficult symptom to treat. But I think it's important to recognise the potential inputs or influence that menopause and hormonal symptoms might be having. So particularly sleep disturbance from hot flushes may contribute. I think that you do feel more tired around the menopause and perimenopause. I recently took part in a debate about the best way of treating fatigue in MS, and again, it's not easy, and probably combination of lifestyle recognition. There are some really good occupational therapy interventions. There's something called the Facets course, which is available on the MS Society websites, together with psychological interventions like CBT and maybe ACT therapy, but also the use of perhaps short-term medications such as amantadine, modafinil can be useful, particularly if sleepiness is an issue. But again, when it coincides with the menopause, there's certainly no harm in trying HRT. I think we have to accept that it's probably not going to cure everybody's fatigue, whether it's menopausal or MS related, but it might help. So, in conclusion, I think what I would say is that the role of hormones in MS is complex, but we definitely need to do more research. And there is more research being done. So in the UK, I've become involved in a working group where we're looking at mapping people's pathways, and we want to understand where the kind of difficult parts are, and ultimately with an aim of educating neurologists, but also educating primary care and trying to bring us together to best serve our patients. And this is an opportunity for healthcare to be personalised and really identify the cause of symptoms in each individual. If I can do anything for patients, sometimes the easiest thing for me to do is to say in a clinic letter that having MS is not a contraindication to HRT or considering HRT, and neither is being on a disease-modifying therapy. So you can be prescribed HRT as you would with any other women if you've got MS and if you're on a DMT. And we are trying to get the word out that that is the case. So how has my practice changed? So I in the last few years that I've become more interested in this subject, it has changed with the kind of greater knowledge that I have. So I now ask people about their periods and about whether they've got hot flushes, particularly if, in women between the, early 40s to early 50s. And I'm aware that menopausal symptoms may mimic MS symptoms. And in some ways, it's easier to treat the symptoms as if they're menopausal with perhaps a trial of HRT than it is to treat them as if they're MS, because we know that those kind of symptoms can be really challenging to treat. The decision to start HRT, involves weighing up the risks and benefits, and that will be different from woman to woman. And I feel that my role as a healthcare professional in this situation is to really advocate for my patients and trying to empower them so you have all the right information to make the best decision for you. So that is all I really wanted to say. So thank you for listening. And we're going to take some questions. And I put just a little bit of hopefully light relief there. They're my 7 menopausal dwarfs, along with some other resources which I partly used to prepare this talk, but also the Women's Health Concern, which is a really useful source of information, I think. So thank you.
Fantastic. Thank you so much. There's been just fantastic information in there, and actually we're sent some questions in advance, and I can see that some of those questions through the presentation would have been answered, but we'll still try get to as many as we can. So just to let everybody know, the Q&A function is open, the chat function is open, so if you do have any questions you want to submit, we have about 15 minutes, a little under, to get through as many as we can. So with that, I'm going to go to the first one on my list here, and it's around I suppose, so you'd mentioned as part of the presentation there that some of the symptoms of MS and some of the symptoms of menopause are similar. And I suppose the question is, how can somebody actually determine if the symptom is due to menopause or if it's MS? So the likes of confusion, fogginess, and so on.
I think it's really, really hard, isn't it? And I think I think I always recommend patients people keep a diary of perhaps symptoms. And I think particularly early on in the menopause, you might notice those fluctuate around the time of periods if you're still having periods. Ultimately, it may be impossible to know. I suppose, like I said, with the urinary tract infections, you would maybe look out for other neurological symptoms that may suggest that there is something MS related, something new MS related going on. So if it's fatigue along with worsening kind of stiffness and spasticity, could that be, MS getting worse? And or is there nothing else, or are they having lots of hot flushes, a change in periods, which might suggest it's more likely to be menopausal? So it's not an easy one. And I guess the other thing I would say is that having a trial of HRT is, it would need to be a trial of a few months, I think, to decide whether it's, whether that's going to be helpful. But there certainly isn't, GPs, I've got a number of friends and colleagues who are GPs that said there's no harm to just having a trial of HRT and seeing if that helps with the symptoms. There would be no obligation to continue it if you didn't feel it was helping.
Great, thank you. And the next question that came in then that we're going to go to is from somebody who's about to start onto Mavenclad, and they say that they're 47 and they found it hard to distinguish between perimenopause symptoms and MS, and they're about to get the Mirena coil and possibly HRT before Mavenclad in either January or February. They have great praise for their MS nurse, and their question around this is, does it sound like that's an overload for their system in the next 3 to 4 months? It feels like a lot all of a sudden.
I think it's a really tricky question. And I guess what I would say, I always try and, I don't think there's any medical reason why it's going to do you any harm, bottom line. But I guess if you do start a number of different things at the same time and don't feel great, you won't know what's caused it. So I do tend to recommend people don't do lots of things at once if they're making big changes within treatment plans. So I would probably prioritize your MS treatment and your disease modifying therapy, and then perhaps pause on the hormonal stuff until that had settled down. But they're not going to interact with each other specifically. But I guess if you're concerned, then you won't know if things do go wrong, you won't know what's caused it.
What's what with it? Thank you. And the next one then we might go to is, since pregnancy is known to have a beneficial effect on MS, how does menopause affect its course?
So we don't know is the bottom line, and the difficult thing is disentangling the natural history of MS, which in men and women tends to is more likely to progress kind of late 40s, early 50s, which is also coincides with the time of the menopause. So we don't really know whether it's that fall in hormones in women that's contributing to that worsening disability, or whether it's the MS itself. My feeling is that it might be a combination of things, but I don't think hormones are the only answer. So I think it might be a coincidence, but we need more. Ideally, we need more evidence, but I think that evidence is going to be challenging to find because of the difficulty of, like I said, for finding a control group.
And somebody who has written in as well, who has reported progressively, they've been experiencing frequency and stress incontinence that they've reported to their GP and neurologist over the past number of years, and following some investigation they were prescribed medication, but due to potential side effects they didn't end up going on to the medication. They said that menopause or perimenopause was never discussed. Now I know that you touched on this as well in terms of educating your peers and so on. I suppose the question that this person has was, why would a consultant neurologist not raise this with somebody?
I don't think, it's not menopause. it was not high up in the agenda in terms of medical education. I think that's a big, it's a big gap in our knowledge and understanding. And I'll put my hands up and say, before I became, educated about this, which I've done through self kind of directed learning more than anything else, is that I wouldn't have necessarily thought of it either. So I think this highlights, it really does. So there's no, I don't think, last thing I'd want to say is kind of blame my colleagues for not really making that connection, but it does highlight the necessity for this awareness and kind of education. So one of the things I have observed is that a lot of the kind of talks I've been doing have been at nurse-led meetings, and I want to get the word out to neurologists, and that's my next aim.
Well, that's fantastic, and hopefully people begin to see a kind of a change in that and a shift in behavior.
Yeah.
Absolutely. And there's questions here around the likes of kind of supplements, vitamin D, preventative medications, and so on. Would you have a comment to make on that?
Yeah. So I gave a talk, a joint podcast with actually a menopause specialist from Belfast, who, when asked this question, said there is very, very little evidence in terms of treating menopause with supplements. There isn't a lot of great evidence. And there may never be the evidence, because if you have that evidence for supplements, they stop being supplements, they start being a medicine. The vitamin D thing, I recommend all my patients with MS take 4,000 international units of vitamin D, because I think that's important for bone health. I think it's important for, your immune system. The evidence is still very kind of mixed in terms of whether it's really going to impact on disease outcomes and relapses and progression in MS, but it's certainly not going to do any harm. And where I work in the northeast of England, and probably similar to some places in Ireland, the sun doesn't get high enough in the sky in the winter months to give us enough vitamin D from the sunshine. So we're all vitamin D deficient. So we should all be taking vitamin D.
Thank you. There's a question here as well around the role of the use of HRT to treat a monthly excavatioration of MS symptoms associated with menstruation in women of a certain age.
Oh, that's a really good question, and I'm embarrassed to say I don't really know the answer. So you're saying, I guess you're saying that if your symptoms are getting worse around the time of the month, could that be due to menopause? I think that's an area which isn't well researched and there isn't evidence for. So, but certainly it's a very interesting question, and I think we should look for those answers. Was the person menopausal? I didn't quite catch the beginning of that question. Or
so the question is there a role for the use of HRT to treat a monthly excavatioration of MS symptoms associated with menstruation in women of a certain age? I don't have additional information.
Yeah, that's fine. So I think that I think there would be a role for trying HRT and seeing if that helps. Yeah, if you were particularly if you were of a certain age and had other menopausal symptoms, then there would certainly be no harm, because it may be that those symptoms are getting worse because of hormonal factors. Yes.
Thank you. And somebody's wondering if there's a kind of a safety preference in terms of taking estrogen as a gel or orally.
So the caveat to this, obviously, that I'm not an kind of HRT specialist or prescriber, but my reading of the research, and I think either is safe. From what I've read about the kind of, there may be a slight preference for the gels or patches, but I think either can be safe.
Thank you. A question here wondering about the effectiveness of HRT patches in MS and also about stiffness. So whether it's a common factor for women, this person feels that they can't seem to get any answers on what's causing it. They say that they're overweight, only building their exercise back, but would love to have a better understanding of what causes this in their body. So about the effectiveness of the HRT patches and MS, and also if stiffness is an element there.
So first question, do we know that HRT is effective for MS symptoms? Only very small studies have been done. Does suggest a benefit for some women and some women's symptoms. Is it going to affect disease is HRT going to affect disease cause in MS? We don't know the answer to that one. What's causing these symptoms in this individual patient is really difficult to know. So stiffness and kind of what we call medically spasticity, so that stiffness that's due to interruptions in the messages coming down from the brain to the muscles, is really common in MS. It's not a common symptom in menopause on its own, but given that if you've got hot flushes, that may be contributing to sleep disturbance, and that might be contributing to a worsening of that stiffening. So I suspect that the primary cause is MS, but menopausal or hormonal could be contributing to the worsening of it. But I think it's quite difficult to comment without, say, being able to examine somebody or know a bit more about them.
Absolutely. And in terms of diet, there's a couple of questions around diet adjustments, and are there any particular diet adjustments that should be made for MS and menopause?
Excellent question. Whole other webinar about that. So the answer is not that I'm aware of specifically. So there is obviously lots of interest in MS and diet, and is there a specific diet that we should recommend for people with MS? And the answer is there's lots of conflicting evidence. I recommend people I think there is evidence that diet is important, and a healthy, balanced diet. I usually recommend a Mediterranean style diet with lots of kind of healthy fruit and vegetables, healthy fish oils, fats, but not too much in the way of refined sugars and carbohydrates. Regarding menopause and diet, I will confess to not knowing if there's any specific evidence, but certainly I don't know of any evidence for a specific diet for the both of them. But a healthy, balanced diet is what I would recommend.
And the final question that I'm going to ask you is, in terms of exercise, is there any particular best exercise that you would recommend in terms of MS and menopause?
Again, another whole webinar we could do about MS and exercise. And so I usually slightly different. So I recommend Pilates and yoga as probably, if I was to choose an exercise for someone with MS to do, Pilates is probably what I would choose for core strength, stability, flexibleness. I think it has the added benefit of being, having that element of mindfulness and relaxation as well as being quite physically, demanding. There's also, I think, if you can, to do kind of weight bearing exercises as well, and building a kind of, so it's probably a combination of exercise, some cardiovascular with possibly some weights, and something like yoga and stability, yoga or Pilates for stability.
Great. Thank you. So look, that brings us to our 8:30 mark. And again, Dr. Petheram, just to say thank you so much for your time, for a fantastic session, for all of the answers to the questions. We have lots of really positive feedback here from participants. So thank you so much for your time and for your expertise.
Thank you so much for having me.
Just before we finish up, just to reiterate what Aoife was saying there, we didn't get to all of the questions. There's been so many, but if tonight has thrown up any kind of queries or questions for you around your symptoms or around menopause, we'd suggest that you go back to your GP and your neuro, and you're armed with some more information now, and research and knowledge are powerful in terms of knowing what to ask and to maybe advocate for yourself. So we're really sorry. It's been very successful, and lots of questions. So I know sometimes people want them answered in the moment. We can't do that for everybody, but absolutely go back to your neuro or your GP or both and explore some of the options more maybe. And thank you to Dr. Petheram.
No problem. Pleasure.
Cheers. Thank you. Thanks, Aoife.
Thank you. Take care.